Let's examine an interesting case involving a 62-year-old male patient who had experienced chronic knee pain for several years. He underwent knee replacement surgery, however, the procedure did not alleviate his symptoms. Persistent pain following the surgery raised concerns about a possible infection, prompting a biopsy for further evaluation. This is the excisional biopsy of the patient's knee tendon tissue. At low power, we can see dense fibrous tissue with areas of increased cellularity. Let's now take a closer look at these regions. This is intermediate power. We can see haphazardly arranged cells, predominantly in linear arrangement, and others single cells. High power, the tumor cells exhibit nuclear pleomorphism, with significant variation in nuclear size and shape. Some nuclei appear small and spindled, while others are enlarged, with occasional nuclear inclusions. The nuclear contours range from triangular to round and irregular forms. The background reveals abundant myxohyaline stroma. This is a higher power view of the tumor cells. Once again, we observe marked variation in nuclear shape, giving the impression of highly pliable nuclei capable of significant distortion. We also see that some tumor cells exhibit abundant, dense eosinophilic cytoplasm, and occasional cytoplasmic vacuoles are also present. Based on these histologic features, what is your diagnosis or differential diagnosis? How would you approach the diagnostic workup for this case? Immunohistochemical staining demonstrates that the tumor cells are positive for cytokratins, including AE13 and CAM5.2. They also express vascular markers such as ERG and CD31. The tumor cells are negative for desmin, SMA, S100, and SOX10. Nuclear expression of INI1 is retained. Given this immunoprofile, what is the most likely diagnosis? The diagnosis is epithelioid hemangioendothelioma (EHE). Epithelioid hemangioendothelioma (EHE) is a malignant vascular neoplasm characterized by epithelioid-appearing tumor cells, as its name suggests. Clinically, EHE is considered less aggressive than angiosarcoma. Approximately 10% of cases recur, and another 20% metastasize. EHE affects a wide age range but predominantly occurs in younger individuals, with about 50% of patients under the age of 40. It has a broad anatomic distribution and can arise in the skin, superficial and deep soft tissues, visceral organs such as the liver and lungs, and even in bone. Essentially any site or organ can be affected. EHE exhibits a wide range of histomorphologic patterns. Some tumors are paucicellular with abundant myxohyaline stroma, while others are hypercellular with minimal stroma. Tumor cells may be arranged in cords, nests, solid sheets, or as single cells, often seen floating within the stromal matrix. This morphologic variation can make pathologic diagnosis difficult. In addition, some cases may show spindle tumor cells with prominent nuclear atypia, with even giant tumor cells. Again, it can be challenging to diagnose. With careful examination, occasional cytoplasmic vacuoles can often be identified. These so-called blister cells represent primitive vascular lumina. In some cases, red blood cells may be seen within these vacuoles, supporting their vascular nature. This is another picture highlighting blister cells with red blood cells inside these vacuoles. The stroma of epithelioid hemangioendothelioma, known as myxohyaline stroma, is a key diagnostic feature. It ranges in appearance from basophilic myxoid to lightly eosinophilic hyaline or chondromyxoid. This distinctive stroma is consistently present across EHE cases and is often the first histologic clue that suggests the diagnosis. This is a skin biopsy. At this low power, we can see that the surface epithelium is reactive look and the dermis is hypercellular. At high power, the tumor shows eosinophilic spindle cells arranged in interconnected cords. The cytologic features alone can be challenging to interpret, with a differential diagnosis that includes myofibroblasts, myoepithelial cells, smooth muscle cells, and even melanoma. However, the presence of characteristic myxohyaline stroma in the background provides an important diagnostic clue. This is a case of epithelioid hemangioendothelioma involving the skin. This is a soft tissue case. We see adipose tissue at the periphery of the specimen. The tumor has large areas of necrosis and dystrophic calcification. Here we see necrosis at the right upper corner of the picture. The tumor cells in the left side of the picture are embedded in the characteristic myxohyaline stroma. This is an EHE of deep soft tissue. At high power, we see epithelioid tumor cells at the left side of the picture, and spindled tumor cells embedded in the characteristic myxohyaline stroma. The tumor cell nuclei are pliable and shows different shapes. This is a liver biopsy. At low power, we see that the normal liver parenchyma is completely replaced by tumor. On high power examination, the lesion is paucicellular with abundant myxohyalin stroma, a hallmark feature of EHE. Occasional blister cells are also identified, further supporting the diagnosis. This represents epithelioid A involving the liver. This is a lung biopsy. At low power, we can see these nodular lesions involving the pleura. On high power examination, the tumor is composed of a mixture of epithelioid and spindle cells embedded in characteristic myxohyalin stroma. This is an example of EHE involving lung. This is a gastric biopsy. At low power, the mucosa shows foveolar type epithelium overlying an abnormally hypercellular lamina propria. On high power examination, characteristic epithelioid tumor cells and blister cells are seen embedded within a distinctive myxohyalin stroma. These findings are consistent with epithelioid hemangioendothelioma involving the stomach. Immunohistochemically, EHE tumor cells are positive for vascular markers ERG and CD31 as shown here. Tumor cells are also positive for cytokeratins. CAMT1 is another sensitive and specific immunohistochemical marker for EHE. Although this antibody is only available in select laboratories, it can be extremely helpful in distinguishing AA from other vascular neoplasms, particularly angiosarcoma and epithelioid hemangioma. This is because genetically, EHE is characterized by the WWTR1 CAMT1 gene fusion, which serves as a defining molecular hallmark. While diagnosis is typically made based on histologic and immunohistochemical features, molecular testing is available when needed. This PowerPoint slide, shared by Dr. Hornick, highlights the diagnostic utility of CAMT1. CAMT1 is positive in approximately 85 to 90% of EHE cases, making it a highly sensitive and specific marker. Importantly, it is negative in all major histologic mimics of EHE, further supporting its value in differential diagnosis. A distinct subset of EHE harbors YAP1 TFE3 gene fusion. This variant exhibits unique morphologic features, including increased cellularity, a purely epithelioid cytomorphology, and more pronounced nuclear atypia. It can closely mimic carcinoma, making accurate diagnosis more challenging. Here are more pictures of TFE3 variant of EHE. The tumor cells are epithelioid cells with abundant cytoplasm, mimicking carcinoma, especially renal cell carcinoma and hepatocellular carcinoma. Immunohistochemically, it is positive for cytokeratins, vascular markers, and TFE3. This is a case of TFE3 variant of EHE shared by Dr. Billings. We see clusters of epithelial cells. Based on morphology only, it is indistinguishable from carcinoma. This is another case shared by Dr. Hornick. My first impression was renal cell carcinoma. Positivity for vascular markers such as CD31, CD34, and ERG, along with TFE3, helps distinguish epithelioid hemangioendothelioma from carcinoma. Interestingly, the TFE3 rearranged variant of EHE, despite exhibiting more pronounced cytologic atypia, tends to have a more favorable clinical course compared to the classic WWTR1 CAMT1 fusion variant. This finding is somewhat counterintuitive and highlights the importance of integrating molecular and morphologic features in diagnosis and prognosis. In summary, epithelioid hemangioendothelioma is a malignant vascular neoplasm with a broad anatomic distribution, occurring in sites ranging from skin and bone to visceral organs. Although it can affect patients of all ages, it is more commonly seen in younger individuals. Histologically, EHE demonstrates wide morphologic variation, ranging from paucicellular to hypercellular tumors, and cytologically from spindle-shaped to epithelioid cells. These variations can make diagnosis challenging. However, the presence of characteristic myxohyalin stroma as well as tumor cell pleomorphic pliable nuclei are valuable diagnostic clues. Immunohistochemically, EHE is typically positive for cytokeratins and vascular markers such as CD31, CD34, and ERG. Two molecular subtypes have been identified, the classic WWTR1 CAMT1 fusion and the less common YAP1 TFE3 fusion variant. In diagnostically challenging cases, molecular testing can aid in confirming the diagnosis.